So questions for the panel? While you're thinking of those questions, I have one. It was interesting to hear the randomized trials this morning and part of the afternoon. And what is striking about this panel is that it moved from those to translation and dissemination and scaling. So I wonder what advice you would give all these individuals who conducted the RCTs about scaling and scaling these programs and making them effectiveness studies rather than efficacy studies. Particularly, what are the barriers that you, I mean, I think that that Catherine really outlined some of those barriers, but it would be helpful to consider the barriers that you all encountered as well.
So I'll start, and I would say for people doing those efficacy trials, I would not ask them to change their trials and make them something scalable, because I think for an RCT, if you're trying to show an impact and look at what impact, say, exercise or weight loss has on a disease outcome, you know, you want to make sure you get the change, because otherwise you want to get sufficient change to see an impact on disease. And so I don't know that.
Well, let me be clear. I'm not talking about changing the efficacy trials, but moving from efficacy to effectiveness.
Okay.
So I do think that that question is relevant to efficacy trials. So to pick up on what Karen is saying, I agree with what you said about getting an effect, but I think we want to start to build the partnerships with end users and those with whom we will disseminate right from the beginning. So if those people, and that includes the patient voice and includes the patient advocacy organization voices and the clinicians or settings that we think will be involved with. I think the earlier we involve them, the better. And if that can be at the point of an efficacy trial, that's fantastic. But if not, because we probably weren't that far ahead, 10 years ago when we started these trials, to get going, the Healthy Living After Cancer partnership with the cancer councils, that process took 2 years of me flying across the country talking to my colleagues at the cancer councils about what their survivorship needs were in the lifestyle space, the programming they were offering, and what they thought about this idea of an integrated telephone program.
I think one of the things that's been brought up throughout the day that's relevant to what you've asked is cost effectiveness. And I think that that's a red herring, and I think it's I think it's a rabbit hole, because I don't know that we're always, I mean, it's amazing that we've been able to show the cost effectiveness that you've been able to show with DPP. That's amazing. But I think that there are many, many things that we do in healthcare that are not cost effective. And I think what I was taught by my colleagues at the Leonard Davis Institute at Penn, Principal David Ash, was that if a healthcare system starts to say, well, show me it's cost effective and then we'll do it, what they're really saying is we're never going to do it, because we wouldn't have proton machines. There are many, it's just one example, but.
Yeah, I mean, I think the answer is probably all the above, right? I mean, it has to incorporate some cost effectiveness approach somewhere to address the barriers to scalability. I'm not sure where that will be yet, but the kinds of things that could be looked at, I think, particularly in like Katie's work, might be, is there a return, a shortened latency in return to work, yes, or is there an improved adherence rate to overall treatment by participating in something? I think it may not be for the, to Katie's point, it may not be for the healthcare system that you're documenting cost effectiveness, but for policymakers and et cetera. If you can't cite those kinds of data when going to the OMB or to whomever to be talking about kind of coverage decisions and things like that, you're going nowhere. So, with the increasing number of survivors, the folks who need help, I think that we have to use every policy tool that we have in our bag of tricks, and cost effectiveness is one that's particularly effective.
Yes.
Hi, Jennifer Ligabelle from Dana-Farber. Just to make a point about a lot of the ongoing large-scale trials, I think it is notable that majority of these studies do use telephone-based approaches at this point, with the exception of the trials that really are specifically focusing on physical activity. I do think that that approach took into consideration for many of these trials, how would we be able to disseminate these if we did show benefit? I think one of the things that in designing these trials that we will have to look at subsequently is dose, because as we think of cost effectiveness, and to Karen's point earlier, there was a lot of attention paid. With these studies, we have probably the unique opportunity to show whether these types of interventions improve outcomes. And if we aim too low, we are likely to miss a potential benefit. And I think that subsequent trials may need to look at, well, do you really need 42 phone calls or 3 years of intervention, looking at different doses? And hopefully we can, by that point, validate something as an intermediate marker so we won't have to do all these 10-year trials. I do also just briefly want to say something about the cost effectiveness of these studies. And this is one of the things that's so difficult when you're looking at trials that have cancer recurrence as an endpoint, especially in a disease like breast cancer, where the natural history of the disease is so long. It would be lovely to be able to do a study and show in 18 months that you can save money by having somebody take part in a lifestyle intervention program. The reality is you're probably preventing recurrences 5 years later. And although the amount of money that you save by avoiding years of expensive chemotherapy is enormous for even one patient who avoids recurrence, it's really hard to use that metric. So I think the idea of looking at things like return to work, productivity, other comorbidities is going to be very important as we develop the cost basis for these studies.
Christy Beffert, University of Kansas Medical Center. I had a question for Matt, or really anybody on the panel that's sort of dealt with continuity of care issues. But thank you for those presentations. I think all of them are really exciting. But my question is about the communication piece back with the healthcare provider, particularly when we're talking about community integrated healthcare. And you mentioned that the Y has purchased Athena EMR, and I'm really curious how you are integrating into the variety of different EMRs that are out there. Are you working through a health information exchange? How are you actively communicating back with the providers?
Yeah, thanks for the question. And for any of you who've been in systems where you implemented an EMR, I see lots of nods. We started implementing Athena on January 1st. So, you know, the things that... Yeah, the things that we're tracking right now to just kind of find a glimmer of hope to get us through every day are, did the number of requests to the help desk decline today? So like we're really, you know, kind of working through the day-to-day of stabilization of our platform, training, you know, 4,000 people to use an EMR with new coding processes, et cetera. You know, has been quite an undertaking, and we're still working on it. I think what I can say is that we wouldn't have invested in this or you know, partnered with Robert Wood Johnson to create this kind of infrastructure if continuity of care wasn't exactly what we were after. We know from the analyses that we have been able to do on a variety of the programs I listed that participants in YMCA programs who are referred by a doc, who consent, I should say medical professional, who consent for us to share information back to that referring individual, do better. They attend more sessions. They, you know, in the case of DPP, lose more weight. So in configuring the Athena Health platform, we've made sure that encrypted email, secure fax, you know, things like that are all possible. Athena worked for us because it's a cloud-based single instance EMR, as opposed to like Epic, which can sell one instance to GW and one instance to Hopkins, and they can't necessarily communicate. You know, we're in one system for our whole network. And we're trying to figure out with a DPP study coming up this summer with the AMA how our platform will work with Epic, Cerner, and one other that I don't think we've figured out who that last one is in that particular place, but developing kind of the implementation guides for our staff on how to work with a physician that's on a different platform will be produced this summer.
So are you going to be working through health information exchanges or trying to do direct connections?
How do we get direct connections to
the
the
different
platforms?
platforms, yeah.
So the AMA has been particularly helpful for us and other medical societies, the AAP, the ACPM, et cetera, to find physician champions to go and do practice-based kind of continuing medical education work, to get those physician champions to work with WISE to kind of troubleshoot these things. In our CMMI project, that led to in the communities that had practices embedded in their recruitment and engagement efforts, it led to a 41% increase in enrollments and a 17% increase in various yields from referrals, the AMA's actions. So we've been lucky to partner with medical societies that have kind of then worked with practices, and hopefully we can take those to scale.
Hello. So my name's Chris Barnes. I'm from the University of Utah, and I have like a comment question. So I'm a physical therapist, and I was very excited, Dr. Schmitz, to hear you talking about the way that you were working with physical therapists to integrate or to get good communication back and forth with getting your patients to get the services that they needed. At the U, we're working on integrating physical therapists onto clinical teams, so outpatient clinical teams at the hospital, and then also working on coordinating the activity between outpatient and inpatient care. And it's using the skills of physical therapists both to triage and evaluate people based upon physical activity, and especially mobility is what we're focused on, more so than more generic or general ways to approach fitness and physical activity, but then also I forget the second part, but anyway, yeah, the important thing is that physical therapists already have these skills, and physical therapists are interested in kind of developing this coordination with other treatment teams and with other providers. And also, PTs are late to the evidence-based practice game, but that is definitely something that is happening very, very strongly, pushed by the APTA and all PT education now. And so I advise everybody, and this is kind of presumptuous on my part, but finding PT partners to work with. There are incentives for PTs now to work with researchers in this way, and PTs have this really large skill set that's being underutilized right now as far as dosing exercise and doing these triaging activities that don't come as naturally or aren't the purview of other providers. So, thank you.
Thank you for your comment. I actually was on a phone call with the president of the APTA last week, talking about a key issue that's related to what you've said, and that is the longstanding misunderstandings between the exercise professional community and the physical therapy community with regard to scope of practice. And I am challenging Mr. Moore to the idea that for the first time, I think ACSM and APTA are going to come together and try to solve this one specifically in the space of oncology.
And we definitely have experienced that discontinuity in our own work as well. So.
So Katie, you talked a lot about sort of safety issues and how do you match people to programs, and having spent an unfortunate amount of time in PT for my age, I can tell you I generally leave with a Xerox that looks like it was drawn in 1986 and has been Xeroxed like 100 times. And I think about, how lit up the whole room was during our patient story about using Skype. And yet, knowing that the research community getting something from idea to implementation takes a frighteningly long period of time, I've heard that Skype doesn't often get approved by IRBs because it's not HIPAA compliant. And so I'm just sort of wondering, as we think about, how do we reach people in rural areas that Christy talked about and these challenges, you guys may have insights about what's being done in clinical trials that aren't yet published. Are people using Skype or video-based technologies to, help maintain safety for people who can't get back to a clinic, can't show up, live in a rural area, or, is that technology use too far out there?
No, it's not. We're actually building something with Avon Foundation money right now called Nurse Amy, accessing or addressing, metastatic individuals every day. It's specifically for metastatic breast cancer patients who are rural and at distance. Because we know that they will include retired waitresses who are like, what is this? Who will not have any tech savvy. We've chosen not to do any video with them. We've chosen to do a tablet that they're going to interact with, and they're going to have a little nurse on it that will talk to them. But then once a week, we'll have a navigator call them. So that's our first attempt. I'm so interested to try Skype if we can figure out how to teach them how to use it. But I think that's coming. The other thing that we have to recognize is that, where's Christy? We have people who don't have any Wi-Fi in central Pennsylvania who we have people with dial-up or nothing, right? Do you? Yeah. They don't use it, right. So we're actually having to give them devices that have cellular data. So,
Yeah, so and we're just about to start, actually, we just recruited our first participant on a trial with endometrial cancer survivors, a weight loss trial that is using information on an iPad, and we're doing FaceTime on the iPad. So we're providing them with the iPads. We're doing the coaching, both coaching about behavior change, but also one of the conditions does have resistance training with resistance bands, and they're doing that via FaceTime so we can observe their form. So we'll see how it goes.
Hi, Tina Shi, MD, Anderson Cancer Center. I'm a health economist, so I'm very happy to hear all the talk about cost effectiveness analysis. So 2 quick comments. One is it's very, very important to involve your health economic colleague at the stage that you're planning the trial, because once you lose the opportunity to collect the data, it's too late when the trial is done. And there are validated instruments to collect productivity information. You can ask patients to collect cost diaries. So those are tools that you can use. The other thing is we actually talk to payers about what exactly do you need. And a lot of time they don't actually understand cost effectiveness analysis. What they want is budget impact modeling, because that affects their bottom line. So if you show them cost per quality, you have to convince them what does quality mean. Do they agree with the way you assess that? But with budget impact model, they actually understand what's the impact. And for that kind of model, you also don't need to model into lifetime, because what they want to know is in the next 2 to 5 years, what's going to happen if I do this. So I think that's another thing that you need to keep in mind when you're trying to provide evidence to providers, to payers. Those are the kind of evidence you need to give to them in addition to cost effectiveness analysis.
Hi, Crystal.
Yeah, just a quick response. I think that's really, again, really important around this whole cost effectiveness thing. Different audiences want different accountings, right? So when we do cost effectiveness or cost savings evaluations, for the feds, you got to use the CBO kind of scoring metrics, right? But payers are looking for a different kind of analysis. So again, really feel like that has to be a tool in our tool belt.
Hi, Crystal Dunlinger from Fox Chase Cancer Center. So I'm a clinician, and Katie, to your point, don't underestimate the burden of clicking. If you interrupt workflow, that kills best intentions. But I do have a question to Matt and to those that are providing information from their programs back to clinicians. Are you tracking what clinicians are doing with that information, or are you planning on tracking it? And if you have been tracking it, what sorts of things you're finding when you send Mrs. Smith's report back to, myself as the GI oncologist?
We have not been tracking it. I think that we would love to get engaged in a variety of different kinds of research protocols on this. I think, there has not been enough research on the Livestrong at YMCA program in terms of clinical integration. And, I think with the opportunity to work with Athena and those kinds of things, we should have new opportunities. Like I said, the best examples I can share from our experience in clinical integration with DPP.
I'd like to thank the panel for keeping us on time. There's now a 10-minute break.